So again, welcome everybody. And Zhang, it will be now you going first, presenting the paper towards replacing late gadolinium enhancement with artificial intelligence virtual native enhancement for gadolinium-free CMR tissue characterization in hypertrophic cardiomyopathy. The Oxford team has done fantastic work on mapping, so I'm really looking forward to your presentation, and just take it from here.
Yeah, so thanks, Matthias, for the introduction, for the invitation. So in this paper, we're presenting a new artificial intelligence virtual native enhancement imaging technology to replace late gadolinium enhancement for gadolinium-free CMR tissue characterization, and is first validated in hypertrophic cardiomyopathy. So as a background here, late gadolinium enhancement, or LGE, has been the clinical imaging gold standard for myocardial tissue characterization, but it requires the injection of a contrast agent, which has a few limitations. Therefore, eliminating the need for gadolinium administration can significantly shorten the scan times and reduce the cost. So native CMR or pre-contrast CMR are alternative means for tissue characterization. For example, there are like cine imaging and a native T1 mapping. And notably, T1 mapping appears the most promising to correlate with the LGE in signals for revealing myocardial abnormalities. However, the clinical utility of T1 mapping has been hindered largely by lack of standardized interpretation and post-processing confounding factors and diagnostic specificity. So we hypothesized that native T1 mapping may be transformed into virally diagnostic images similar to LG images. And this leads to our concept of virtual native enhancement, which exploits and enhances the existing contrast signals within the native T1 maps and the cine frames. And in this paper, we validated in the hypertrophic cardiomyopathy. So in method section, we first introduced the new network design. So for more intuitive description of the method, I'll just go straight to this figure 1. So the deep learning virtual native enhancement generator has 3 parallel streams of encoder, decoder, UNet neural networks to extract features from pre-contrast scenes, invariant recovery weighted images, and the parametric T1 maps. And all these deep learning image features are then concatenated and input into a further neural network block to fuse this information and produce a virtual native enhancement image. So the neural network is trained using a generative adversarial neural network method, which has a discriminator that is trained simultaneously with the generator to encourage the generator to produce images that looks like LGE and detect lesions like LGE. So for image quality assessment of VNE and LGE, we asked 4 clinical assessors to score the image quality blindly, guided by a 5-point categorical scale. So let me show you in this picture. So this is like image operator is guided by this 5 categorical scale to score the LG and the VNE image quality. And when they input a score here in this bar here, it is actually recorded as a sort of continuous score from 0 to 100. So this guarantees first is intuitive for the human observer, and second is actually more accurate for the following statistical analysis. And we actually recommend this type of scoring approach if the human observer scores is required for analysis. And the lesion quantification is analyzed in a semi-automatic approach, and we use the standard full width at half maximum thresholding method for LG and VNE. And so as we know, like in HCM patient cohort, not only they have like focal lesions in LG, but many times we've seen those intermediate lesions. Like, let me show you again this example here. This is an LG image from a HCM patient. We not only see this focal lesions, but also sometimes those subtle intermediate lesions in LG image. And those signals has been reported in literature to correlate with the HCM patient outcomes as well. So to capture all the signals, we not only use a full width at half maximum threshold method as shown on the left-hand side, but also we lower the threshold using, for example, quarter maximum and full width at eighth maximum to capture more subtle lesions as realized here in yellow and the light blue color here. And putting all them together, we have like a what we call like progressive thresholding map method to capture different extent of LGE and VNE lesions. So in results, we used about 2,700 triplets of T1 maps, CNIs, and LG images for the training. And then we tested independently on 345 triplets of images from 124 patients. So for image quality, let me go straight to figure 3 for like more intuitive results. And we can see that all 4 operators scored VNE as shown in green color here to have a significantly better image quality than LGE as shown in yellow color here. And also the average score of the four operators is telling the same story that VNE has better image quality than LGE. Now here's a few examples demonstrating VNE image shown in the bottom row has a significantly better image quality and a more consistent appearance and a more defined myocardial border than the LGE images. So for lesion detection, let me show these results with this figure, and we have 7 patient examples from the 7 columns, and from top to bottom we have the native T1 map that's carefully windowed to reveal the HCM lesion, and we have the contrast-free VNE images and the contrast-based LGE images, and then we have the VNE and LGE quantification and realization using the progressive thresholding method as described earlier on. And we can see that the contrast-free VNE revealed characteristic HCM lesions in those hypertrophied segments and in like anterior, inferior, right ventricular insertion points here, and it's actually in high agreement with the LG images in the distribution and the pattern of the lesions. So for lesion quantification, VNE correlates strongly with LGE in quantifying hyperintensity lesions, as shown in this right color here, but also in more intermediate intensity lesions, like shown in this rest 2 panels. But we also noticed VNE has like a bit lower range quantifying the lesions comparing with the LGE, especially in the hyperintensity lesion. So to account for this, we adjusted the VNE thresholds to, for example, lower it from 0.5, which was full width half maximum, to 0.35, and this brings the VNE quantification to like identity correlation with LGE in this hyperintensity lesion, but also intermediate intensity lesions, as shown similar here in the rest 2 panels. So this is all for the results of this work. And in discussion, we presented an AI technology that translates native T1 maps and together with the CNIs into a widely recognized presentation for LGE, a format immediately ready for standard clinical interpretation. And the AI here is effectively acting as a virtual contrast agent. And in other words, it produces a virtual LGE image without the need for gadolinium. So I'll just go to this a few like a clinical impact we are highlighting. For example, for T1 mapping interpretation, it provides alternative to translate T1 maps into the common language of LGE, whose interpretation is widely accepted and understood in routine clinical practice. For HCM assessment, VNE can obviate the need for repeated administration of gadolinium and allow more frequent CMR follow-ups. And the apparent VE signals to subtle lesions, as we've seen in the figure, may potentially lead to better HCM risk stratification and the treatment. Sorry, I forgot to mention this bit. If you look at the results, there's like a perceivable trend of VNE highlighting subtle lesions at the lower lesion range comparing with LGE in this plot. And actually, we showed an example here showing that LGE detects something, you see some signal here, but VNE showed the signal clearer than LGE. And this may lead to potential like a better risk stratification for HCM patients, but it's pending further validation on the HCMR outcome study. And so finally, with further development, we may lead to a novel Gadolinium-Free CMR scan protocol, and this could expand the capability of CMR, and also the contrast-free nature of this technology could lead to substantial cost saving for CMR scans. And finally, in conclusion, we showed that VNE imaging is a new CMR technology that resembles conventional LGE, but without the need for gadolinium-based contrast agent administration. Yeah, that's all I want to highlight from our paper. Thank you very much for your attention.
Thank you very much for the great presentation, and of course this is really amazing, and also including Vanessa and Stefan, who worked together with you on that paper. Just a few questions, and for the others, please post questions into the chat. Before I take those, just from my own curiosity, so you also included the cine images or the information from the tissue of the cine images, right? Which is technically a T2 over T1, or do you mainly use it for the contouring or for defining the anatomy?
So we input the new networks, the stack of cine frames. Yeah. So this gives not only the contrast information, but also the wall motion information from cine.
Yeah. Okay. Yeah, that makes sense, and that's the beauty of AI, that you can basically incorporate a lot of information that would be terribly difficult for our brains to get our minds around. So that's great, and I think it's especially useful in cardiomyopathies, where I think these subtle lesions play a much more important role than in MI, where you have a solid replacement fibrosis, whereas in cardiomyopathies, this may not be solid at all. So then a quick question, how robust was this really? I know we show how it works, but was there, so if you would take 100 patients, what would be your guess for someone who would get started with that, in how many you would get this kind of result? Maybe also, of course, involving Vanessa and Stefan to chime in if you like.
Yes, so first we see like a strong correlation in this patient cohort, and also in this testing data, we did not see like any false negative VNE imaging. And of course, it would be we will need to probably further validation on a large multinational multi-center study before really applied it to patients and used in clinical practice.
Can you hear me, Dr. Friedrich?
Yeah, now we can hear you. You're a little bit on the soft side, so if you can speak up a little bit would be great, but we can hear you.
Okay, all right. Yeah, so me and another fellow, we looked at the 345 pairs of data sets, the testing data sets. So we actually looked at them individually, independently of each other, to see specifically whether the VNE would have introduced a false positive, introduce a blob when there wasn't any, or missed any. And we didn't find anything like that. But of course, this is currently only validated in hypertrophic cardiomyopathy, because sometimes people mistakenly think that, oh, now we can apply it to, chronic MI or acute MI, acute myocarditis. No, we still need to train the machines to be able to learn those things. And at the moment, we haven't take this machine that's trained on HOCM data and applied it to other pathologies, but we are doing that right now. We have to do it step by step.
Yeah, and that also relates to the question that came from Amin Amyar in the chat. You can also read it, I think, there. So the concern here is that the adversarial networks that we're using, they basically are based on a certain ground truth. And of course, if you apply this to the data that you have, you're basically, it may not be as well applicable to others, and you partially refer to that in other diseases. But over time, do you think that that these engines, let's call them, or these algorithms, could then be generalizable enough so that we can basically throw in a patient with, let's say, sarcoid, and we would still get the machine to figure out the areas? And what is your impression? And you said you did not personally see that, but do you see the risk at all that we get some generated false information from that?
Yeah, so the second question first, which is you have to make sure that they're good quality. Because if they're not good quality T1 maps, it will generate bad VNEs, or if it's like, even in the training, if you have a bad real late GAD, then you're training the machine to do incorrect things. So we have to make sure that the image quality is good first. And what we're doing right now is to incorporate a quality control measures, in these algorithms. So that's really important. And I think Qiang is also working on things like saliency maps so that the machines, whatever they're doing, you can actually see where their attention is at. Are they looking at, the anterior wall or the inferior wall? How are they doing this? So it's not so much a black box where you throw something in and then outspit something and then you don't know what happened in between, and there's no audit trail. And audit trails are really important for clinical applications. Secondly, the generalizability. Yes, of course, ultimately you want to be able to say, any patient that comes in for some, cardiomyopathy assessment or any assessment, is a scar. You want the machine to be able to deal with that, but to do that, you have to, I guess, unleash, the machines to, a very mixed heterogeneous data set and see how it deals with it. I'm not sure we're there yet. Because I think it goes in. Qiang can probably answer some of this because the machines can sometimes forget things, and if you train them with new data, they remember the new things. Right, Qiang, can you speak to that, because that's something specific to machine learning?
I have to remind everybody we want to be respectful of the time. Just keep it short, because I would like to get Malgorzata to get prepared for the next round. And there's still two questions. Maybe you can incorporate them somehow. There's from Venkatesh, the T2 map, and I guess that would be probably helpful in the differentiation of acute versus chronic. I think that would be interesting to. And then the question I also would have had at the end is this model somehow available for others? Okay, Qiang.
Yeah. So to quickly comment on this few questions. The first one, the derivative of the adversarial neural network method. I think it's probably like it's giving a wrong impression that the GAN models is creating false information. But the fact is that a GAN model is just a derivative, like a neural networks, like showing this image with like a specific training strategy. And you can actually control the training strategy to control the behavior to make it like more imaginary, or to make it to stick to the data set. So it's all about training it properly to avoid creating false information. Because after all, if you just reduce the weights to very minimal to zero, it becomes like a standard generative neural network models. And also it's all up to the data. If this data is good quality, as Vanessa mentioned, and there's like a clear correlation, then it will learn this role instead of like creating false information. And for the T2 mapping data, yes, I think we mentioned somewhere in the paper that incorporating T2 mapping data would probably help improve the information, improve the performance, because the more information it has, the more information it can incorporate in the deep learning models, and it is like under training, they can figure out all the correlation to predict the results.
Yeah.
And the trained model. So we are currently still working on the models on this pathology and other pathologies. So at the moment, it's not available, but we aim to make this method disseminate this method at some point.
Okay, thank you very much. This is really a kind of a, to me, smells like a landmark study. And there are lots more questions about the actual mechanism of the T1 increase, for example, here. And so there's a lot of interesting stuff around that, but we'll have to move on. So if you could unshare your screen, Qiang. So, and I would like to ask Małgorzata Polosin from Zurich now to present her paper that uses not the mapping, but uses strain. And the paper is called Segmental Strain Analysis for the Detection of Chronic Ischemic Scars in Non-Contrast CMR cine images. Małgorzata, take it from here. Thank you very much.
Okay, I hope you can hear me.
Yes, we can hear you.
After the new link, I can't start my camera. It's broken.
Okay.
So I have to apologize for that. But if you can hear me, that's good. Okay, so maybe a less sophisticated topic, but clinically it's working. So it's about segmental strain in chronic ischemic scars based on cine images. As we know, we don't have much alternatives in cardiac MRI for visualizing scar tissue. And many patients, as we discussed, can't or don't want to get gadolinium. So our hypothesis, or it's a fact, that scar tissue has different mechanical properties than remote myocardium. And we would like to, we wanted to test if detection or analyzing segmental strain would be possible to discriminate scar tissue and remote myocardium by the different values of segmental strain that is produced. So it's based on cine images, so without contrast agent. We used a myocardial feature tracking software that works quite nicely on segmental basis, because that's a big problem. Not all softwares are reliable and have good inter-observer agreement in segmental strain. That is reported since about a decade. So we tried one software only, and we had 46 patients with chronic infarcts. Only 5 females, so we have here a bias. It was a retrospective study. Patients had normal CMR scan with LGE as that was as reference standard, and we performed strain analysis in global and segmental strain. So as many groups before, we demonstrated first that global strain is reduced in patients with infarcts, especially global peak circumferential strain, and also patients with preserved ejection fraction but infarcts were visible globally, like they have reduced or impaired circumferential strain. And also we analyzed all patients and all controls. We have also 24 controls with segmental strain. And we discovered quickly that segmental strain, circumferential strain, is able to detect transmurally and subendocardially infarcted segments from remote myocardium. So longitudinal strain was not useful for it, and also radial strain was able to detect transmural scars, but not subendocardial scars. So in the second step, we had 2 readers. I'm sorry that I can't present this picture in the right direction. So 2 readers evaluated cine stacks, and they evaluated those circumferential strain calculations, and had to define where potentially infarcted segments are without knowing where the LGE is, without knowing if it's a control patient or it's a patient with scar. And so that revealed that segmental circumferential strain calculations are able to detect up to 80% scars from all, like LGE was our reference standard and was like yeah, so we saw that those segmental circumferential strain calculations could detect up to 80% of all scars visible in LGE, and evaluating CNE images, of course, was revealed about 53% of all chronic infarcts. So as our discussion or conclusion, we see that segmental circumferential strain is able to detect chronic ischemic scars. But there are also problems because different conditions like cardiomyopathies or even stunt or hibernated myocardium can alter mechanical properties because it's based on mechanical properties. And then maybe stunt or hibernated myocardium would provide false positive results. So impaired strain, segmental strain without showing LGE. So yeah, maybe for now it's a clinically very quick possibility to derive circumferential strain. It takes, I don't know, 2-3 minutes. And if patients can't get gadolinium, maybe you can then you can enhance your visual, your eye. So not just seeing the senior sequences or the T1 mapping, but also try to do the segmental strain analysis for detection of scars if LGE images are non-diagnostic or contrast was not applied. But of course, there are many problems with this method. It's a very basic method, and bigger studies are required to evaluate if it's feasible in a bigger setting or in prospective setting. Thank you very much.
Well, thank you. Thank you very much for the very nice presentation, and you have been very modest. I think modesty is always good in science, but certainly there's also a lot of potential in this. Maybe as you mentioned, the specificity to ischemic scars may be difficult because if you have infiltration and just by chance it resembles an ischemic injury, so that may be very different. But let's face it, in many studies on imaging and other diagnostic modalities, I think there is a little bit almost a mistake that methods are always put out there alone in the desert. But in reality, you do not take a diagnostic information and just blank out all your clinical knowledge and blank out everything else. So of course you put that into context. So that's why I think having a contribution of information, even if it's not answering the question alone, of course is helpful. And then on top of that, I also think, so the paper we saw before where T1 was basically joined with information from the CINE. Of course, as Venkatesh already mentioned, you could add T2, but of course you could also add strain and thereby basically enhance the possibilities of these machine learning algorithms, and hopefully then also get more, let's say, more confidence in the diagnostic accuracy. So again, the question is about the availability. So I think you mentioned the software and that you used, a segment that is used for that. Can you briefly, just for those who are not familiar with how this is working, on a high level, say which information is used to, it's not speckle tracking like Echo, but can you briefly explain how the software is doing that?
Yes, so that's also something that is quite important because this the software uses not, so you have to put an endocardial and epicardial border to define myocardium, like normally in feature tracking software. In this software, it is image registration. So the endocardial and epicardial border are supporting the system, but every pixel is propagated, like is followed. So not only the endo and epicardial border. Maybe that's also one thing why it's working segmentally, because many softwares that work like with not with image registration but they only detect the borders of endocardium and epicardium. They are not very reliable on segmental basis, to be honest, like in my clinical experience.
Yeah.
So because of like every image is registered through the cardiac cycle, and then also segmental differences are maybe easier to detect.
Yeah. Okay, thank you very much. So as there is a question actually from the chat. Iulia Popescu is asking, first of all, she thanks you for the presentation and the great work. And she asked what the minimum percentage of scar per segment is in your patient cohort. And I think it's a question related to the sensitivity to detect really small subendocardial scars. And then there's another one, where syn image acquired before or after injection of contrast agents. So can you address that?
Yes, of course. So first, I think we missed one patient with a subendocardial infarction. So we saw it in LGE, obviously, but it was so low. It was nearly in the apex, and the apex cannot be detected. That's also one limitation. I forgot. I'm sorry. So it's for the 16 segment model. So if you only have an infarction of the apex, it won't be detected. And the second question was, every we acquire CNA sequence is always pre-contrast, always. So it was without contrast.
Mm-hmm. Okay. Another question from Reza Nizafat from Boston. Do you look at location of scar versus abnormality in strain? So was there really a match? And he adds, not necessarily burden of scar, rather location of the scar. So did you perform a spatial match? Yeah.
That is an interesting question. Of course, like the more it's transmural, the more you see like it's matching, obviously. But also I see if I have a big transmural scar, also the some segments adjacent to this transmural scar are also impaired without really showing LGE. So that's also one big problem. But yeah, like the transmural scars, you can fairly say they are matching with this impaired segment in the circumferential strain calculations. Yes.
Yeah, so I think there is certainly, I think the approach is really great. But again, there's probably more to learn about the spatial relationship between the deformation and the actual scar. It can be, I could imagine, quite complex. And then if you add non-ischemic or patchy late enhancement, then the disturbance of the natural deformation may be even more complex. But these are all solvable problems. And also from my end, congratulations to the work. So it's already close to the top of the hour. I want to thank both presenters very much, everybody, for hanging in there and not let hackers like this really get under our skin and get in the way of our work, which is important. And especially, I think the work that was presented today, moving away from contrast agents, this will be something that we will look back in 10 years and say that was really important. And of course, we have to go step by step, but both these papers, I think, represented a very important advancements here. So thank you very much for contributing this great science to the field.
And Dr. Friedrich, I also want to add that, your paper in 2003 with Daniel Mesrogli on T1 mapping in MI, your conclusion, you were already predicting that we can see scars without the need for contrast agents. So, we've come a really long way.
Yeah, thank you very much. No, that's what I learned in my career, that sometimes it takes a lot of time, but eventually the good things somehow eventually mostly prevail. And so I'm very happy to see this all now, also that making its way into clinical reality, hopefully routine reality very, very soon. Okay.
It's a community effort. Yeah.
Yes, and that's what we're here for, and that's also the beauty. So before I let everybody go, Bettina, do you want to briefly want to mention something about September? Or
yeah, so I can try to show the preview for the September 1st next CMR Journal Club. We will look again at strain, and I really liked your analogy of strain being functional analysis on steroids. I have to remember that. That's actually true, and we saw it all together today. So we have two recent JCMR papers. One for strain, SANC strain, for differentiation of different forms of myocardial hypertrophy. And the other paper is on outcome prediction based on strain measurements. So both very interesting papers, and I'm really looking forward to presentations, and would be happy to welcome you all again.
Okay, thank you very much, Bettina. So again, thank you, everybody. I think despite the hiccup at the beginning, this was to me a fantastic edition of our feature of our Journal Club series, and I'm looking very much forward to the next ones, and I wish everybody a great day or great evening wherever you are. Best wishes in it. Bye.
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 Bye.